Hello, this is Dr. Wendy Wood, and I'm going to be recording a mini lecture on balance and fall risk assessment. I'll be also posting other material along with this. So, first of all, about 1 in 3 older adults, or about 30% of older adults over the age of 65, fall each year. And falls are number one reason for fractures, hospitalization, loss of independence, and injury related deaths. Uh, some statistics here, and these again, I just mentioned this, that in terms of these fall statistics, even though I have some earlier dates here, these are things that have not, statistics that have not changed, and I'll be posting some more information on that. So, about 20 to 30% of falls can result in moderate to severe injury. So, about 95% of hip fractures in the older adult over age 65 are caused by falls. And then, scary, frightening statistic, about 20% of those who fall or fracture their hip die within the first year following injury. And then, in terms of quality of life, about 40% of nursing home admissions are related to falls. And even when people are not injured, many who fall or know someone who fall develop a fear of falls that causes them to limit their activity. Short term, this decreases risk of falls. Long term, it's going to increase the risk of falls. Much research on that, and of course, we'll be talking about the ABC scale as a very good tool to be able to assess that. In terms of balance and equilibrium, it is complex and multifactorial. However, it is something easily understood, something that we can break down. It is necessary for survival and daily function. For that reason, there is redundancy in the balance system, and there is an amazing capacity for repair, and falls are prevented, and balance impairments are reversible. Some of the research in terms of balance actually has come through the space industry, which is very important. Some of the tools, because of course astronauts are in a very unique environment. So in terms of the functions of the balance system, first of all, perception, self-orientation, gravity is important, and maintenance of clear visual imaging with the head in motion, the target in motion, or both. And we'll talk about that more. And the maintenance of static and dynamic balance in routine to complex activities. So we want to talk about reactive and anticipatory control. So anticipatory, of course, is walking around things, obstacles. Reactive would be responding to a sudden loss of balance. Balance control is both conscious and unconscious. So those having balance difficulties tend to expend a lot of conscious effort into balance. And balance responses are volitional, automatic, and pre-programmed. So we can look at that as fast, faster, and fastest. Um, basically defining balance is controlling the body's center of gravity over the base of support, with the center of gravity being in that kind of pelvic region in between L2 and S2. And the base of support is what's touching the support surface. So in standing, it's the feet and the area in between. And sitting, it's the buttocks and the thighs. So sitting's pretty stable. And the limits of stability is how much you can move away from stability. So the functional reach test is kind of a test of limits of stability. And that's about 8 degrees forward, 4 degrees backward, and about 16 degrees laterally. So 8 degrees on each side. And that, of course, is going to be influenced by the individual's biomechanical constraints, the task, and the environment. Postural control, anticipatory postural control. We just talked about that in terms of you have advanced planning, you're going around objects, whereas reactive is that quick response to something unexpected. Postural strategies that have been identified and that actually we can train are the ankle strategy, which is like an inverted pendulum, the hip strategy, where the center of gravity has to move more quickly, and that can be facilitated by being on a narrow support or compliant surface. And a step strategy is when the center of gravity is displaced beyond the limits of stability, and the person has to step in order to create a new balance of support or base of support. So this is a model you may recognize from going through your initial PT program, but balance is the interaction of the individual, the task, and the environment. And these are ways we can, think of assessing and treating balance, looking at the person's strength, sensation, and flexibility. And then when is it that they lose balance? Is it when they're dual tasking or lighting? Is it when they're in darkness? And then we can look at uptraining balance in that way too. So risk factors for balance identified by the American, British, and British geriatric societies. This is backed by a lot of research, and this is great because we can look at an objective test, and in the subjective we can gather information to look at how much increased risk of balance someone is in. So this really does point to the fact that evaluating someone's risk for falls, it's got to be multidimensional. We're going to do balance testing, but we also need to look at things in the history. Muscle weakness, history of falls. Someone would be at 3 times risk for falls. So muscle weakness, we can gather by our objective testing, history of falls by the history, gait deficit, observing their gait and gait speed, and balance impairment. That's kind of a no-brainer in a way, but we have lots of balance tests. Use of an assistive device. This is actually kind of complicated, and it really confused me at first, but I read a very good article on how use of an assistive device is actually a fall risk factor, whereas we know sometimes the assistive device is helping someone in order to be less at risk for falls. But there was a very good article put out by the Geriatric Journal pointing out really the fact that when patients are using assistive devices, quite often they have not been trained on them. They may not even be their assistive device. So it's important. It's an important question to make sure that they have been evaluated for that. Visual deficit, important again, that patients are going to see their doctor every year. Arthritis, impaired ADLs, depression, and cognitive impairment. So those are all risk factors we need to look at and combine that. This is another wonderful model of balance by Lou Nashner, who's the person of Neurocom or NATIS that developed the Balance Master or the Sensory Organization Test. And really, you could look at this as an assessment and treatment model too. In terms of falls, first of all, the sensory systems for balance are visual, vestibular, and somatosensory, so we want to test those. We also, again, I just mentioned, we want to make sure the person is getting regular visual exams. Do they have glasses that are up to date? Comparing and selecting and combining senses, the modified CAT-SIB is a good test for that. And we want to look at, well, are there any environmental factors? That's why doing a good history. Where did they fall? When did they fall? What was happening? What surface were they on? What was the lighting like? And then in terms of muscle contractions, we want to look at strength, but we also want to look at coordination. Testing all of those also. Vestibular, there's various different tests that we can do for that. Somatosensory, of course, we're going to look at with vibration, light touch. Okay, so again, the sensory systems for balance: vision, vestibular, and somatosensory. Vision, we do look at subconsciously vertical targets in a room to orient ourselves. With the vestibular, we're oriented with respect to gravity, and somatosensory tells us about where our body is in space. Somatosensory is very important in all the joints of the body, but especially the feet. What environment we are in will determine or influence the sensory systems we use. So, in a stable environment, we're using mostly somatosensory than vision and vestibular. That's when we have good lighting. When the environment is unstable, we're using really about 70% vestibular vision and then somatosensory. So, very important again to find out how the person is losing balance, and also to realize that if the doctor's done a Romberg or we do a Romberg, that's on a firm surface, eyes closed. Truthfully, that's only looking at somatosensory. That's why that modified CAT-SIB is very important. So later we're going to look at some important tests. We want to gather what types of medications they're on, because medications can, more than 4 medications, the person's going to be at an increased risk for falls, and the various different types of medicines. Sometimes, these are unmodifiable risk factors because they may need to be on those certain drugs. Um, and extrinsic risk factors would be things like home safety risk factors. So it's important that we're having the patients, consider, do they have any risk factors in their home? And then with the physical therapy exam, very important to look at the lifestyle, family history, their history, and the neurologic exam. Reflexes if necessary, sensation, strength, coordination, posture. You should have a basic test of vision, and then various different balance testing and the gait analysis. Balance test, a subjective questionnaire is very important, and the activity-specific balance confidence scale and the dizziness handicap inventory are very good. In the objective test, you want to look at vision, vestibular, somatosensory, as I mentioned. The modified CAT-SIB will show you how they're utilizing that. And then strength, manual muscle testing, or functional strength tests like the 5 times sit to stand or the 30-second sit to stand. And then range of motion, if needed, posture, and then pick a balance test depending on the patient, the timed up and go, the dynamic gait index. The functional gait assessment is a higher level test, the mini best or the best. Of course, there's a variety of tests. And really getting a comprehensive look at why the person has a loss of balance. We can, of course, add other tests to that, like cognitive testing.